This is Caroline.
Mary Tess.
Neil.
And this is Laura. Welcome to Med Surg Moments, the AMSN podcast.
This podcast is an engaging look at the lives of and surrounding medical surgical nurses.
We're proud Med Surg nurses, just like you, sharing our stories, insights, and experiences to support you in your nursing journey.
We're here once again at the 2023 AMSN Annual Convention in Las Vegas. And I must say, it feels great to be here together in person with so many incredible med-surg nurses from across the country and around the world. Our topic today is addressing the staffing crisis, recommendations of the Nursing Staffing Task Force. And we're fortunate to have with us two very special guests who will be joining us shortly. But before we get started, let's begin with sharing some more of our convention experiences so far. Tell our listeners how it feels to be here at the AMSN Convention.
It's great to be at my very first AMSN convention. Unfortunately, last year we had hurricane weathers in North Carolina, so I didn't make it out to Texas. And what better place to kick off a convention than Las Vegas? It's been great to actually meet my co-hosts for the first time in person. I'll say that's probably been the best part so far. Great speakers talking about personal safety, and having a background in psychiatric nursing, that's one of those things that's always in the forefront for me. There was a great speaker last night talking about body language and how we underestimate some of that. As med-surg nurses, we're kind of blind to some of those things. Our patients usually are in bed, so we're not picking up on some of the cues. And just interacting with nurses from across the country and hearing staff and ratio stories and just kind of seeing what's out there in the world. So it's just been great to meet so many different people, let alone my co-hosts. How about you, Mary Tess?
Well, I agree with you, Neil. It's been an amazing experience. And I will tell you, seeing everyone for the first time, our co-host podcast team, it's such an amazing experience. I told Caroline, I'm not an AI. You're not an AI. We are real. It's such an amazing experience. Also, I wanted to share one of the coolest too that happened during the convention is that I met my former student from the Philippines. When I saw that he is presenting a poster, I made it a point to look for him. He's been presenting in AMSN. It's just that I haven't had the chance to really be in person. So when I saw him, I was just standing behind and just listening. And then he saw me and he was like, oh my goodness, I can't believe you're here too. And it's such just moment of, I can't believe we're here together. And he's so successful with his career. He's a manager now. And you know, as educators, as nurses, having that person that you have seen they're successful and they're better than you, you're right? They've reached that goal. You have reached that goal. That's a self-fulfillment. So far, it's been so amazing. How about you, Caroline?
Well, as always, it's great to be back at convention. I've attended so many, I've lost count. We have a lot of first timers and we hope it won't be the last time. And so I've been running into all sorts of people. You might recognize this voice if you've been an avid podcast listener. Look who we found in the line at check-in.
That's right. I am here. This is Alyssa, previous original podcast host, to say hello. So excited to find you, Caroline, at that check-in line and happy to come in and say hi to the cast.
Really excited to see you here, and just proves the point that conventions are all about connections and collaborations, and looking forward to hearing from our guest speakers today. Laura, what about you?
Well, outside of getting to meet my podcast co-hosts for the first time after talking to them for a year through the podcast, it was wonderful to meet you guys in person. I'm having so much fun getting to know you, getting to know more of your personal stories and your personal journeys. I've also met some amazing med-surg nurses, people that I intend to reach out to as mentors. I'm learning a lot. I also enjoyed the initial keynote speaker who was talking about leaning into disruption, because as med-surg nurses, there's nothing but disruption. I learned a lot listening to that first session. And I also learned a new term, post-intensive care syndrome. I was walking through the poster presentations and I stopped at that poster and I got to speak with the presenter. And I'm going to go home and do some more research about post-intensive care syndrome. All right, let's move on to our topic and our special guests. It's no mystery that as nurses, we continue to function amidst a nursing staffing crisis, which challenges our ability to deliver optimal and safe patient care. Are there new solutions on the horizon? Will this staffing crisis ever end? Is there hope for the future? With us today to offer the latest insights and recommendations from the work of the Nurse Staffing Think Tank and Task Force is Sarah Delgado and Monica Vanderzee. Sarah Delgado currently serves as clinical practice specialist for the American Association of Critical Care Nurses, where she also focuses on strategic advocacy. Her clinical experience includes working in chronic disease management and palliative care. Previously, Sarah was a clinical instructor at the University of Virginia and has co-edited books on acute and critical care. Monica Vanderzee is a care management nurse at the University of Kansas Health System, where she is presently working to grow the remote patient monitoring program. She has been a nurse for over 20 years, starting as a CNA at a nursing home, becoming an LPN, and then an RN, working in almost every level of adult care. Monica is passionate about advocacy and serves as the chair of AMSN's Legislative Advocacy Committee and represented AMSN on the ANA Staffing Task Force. Sarah and Monica, welcome to Med Surg Moments.
Thank you. We're grateful to be here. I really appreciate the opportunity.
Thank you so much. It's good to be here.
So, ladies, why don't we start by having you both share your story of how you became interested in nurse staffing advocacy and leadership?
My longstanding issue from my early days as a nurse in Med Surg and then in an ICU is in nursing ethics. And what I found was that moral distress is a really common phenomenon among nurses. So I wanted to look at how we could help nurses address that. And there are some problems that cause moral distress that are sort of unavoidable in acute care because patients are very sick, and that is very distressing. But then there's also system level issues that cause moral distress. So that's how I came by my interest in staffing. That's a problem that should be fixed to reduce the distress that nurses are facing. So that's where my passion for nurse staffing came from.
Like you said, I've been a nurse for a long time, for 20 years, and staffing has always been a part of that. We've always had issues with staffing. In 2018, I joined the AMSN Legislative Advocacy Team and started advocating for nurses as well as advocating for the patients that I had been doing throughout my career.
Quick question, moral distress. Is that along the same lines as they talk about moral injury in staffing?
Yeah, the two terms are very closely related, moral distress and moral injury.
And describe the nursing staff think tank and task force. What were they trying to accomplish?
So that's a great question. So the nurse staffing think tank and task force drew out of collaborative work that was co-led by AACN, the American Association of Critical Care Nurses, with the American Nursing Association. So we first convened the nurse staffing think tank in January of 2022 when we were facing the height of the Omicron part of the pandemic and staffing was at an all-time low. So the aim of the think tank was to identify solutions that could be implemented over a 12 to 18 month period to address the staffing crisis. So it's what can we do right now? And that work finished in 3 months. We met every 2 weeks for 3 months and published in April of 2022. We then convened the task force, and the task force's aim was to identify solutions to the ongoing barriers to appropriate staffing. As Monica mentioned, staffing has been a problem long before COVID. So there are ongoing challenges that we faced, and that's what the task force sought to address.
So I have a question. What do you think are the differences between staffing situation prior to COVID and since COVID? If you could identify a couple of things, what changed?
There are two things, and then I'm going to hand it to Monica and let her answer that question too. So first, we had before COVID what we call an experience complexity gap, meaning that care in the hospital was getting more and more complicated. And at the same time, turnover was happening so that nursing experience was getting to be less and less. COVID accelerated that to a vast degree. So we had more nurses retiring and more complex patients. So the gap grew. So I'd say that's an important consideration. And then the other piece is just that COVID highlighted the problem. It made the problem more public than it was before.
I think you summed it up really well. And I think also it highlights the problems that we have with pipeline issues. The task force and the think tank didn't cover those issues specifically because it was kind of out of the scope, but it is definitely something that needs to be worked on by somebody. We don't have enough nurses coming up behind to replace the experienced nurses that are stepping back from the bedside.
That's great. I think the think tank and task force sounds like a practice and theory, like what can we do? And then what's the immediate action? And to speak to exactly what you're saying, during the middle of the pandemic, I was an assistant nurse manager on a card tele floor. And it is exactly what you spoke of we don't have any more experienced nurses. We've burnt them out. They were already hanging on by a thread. And then we just doubled down with PPE and demands and hours. And they're like, I'm too old for this. And they gladly walked away. And then you have these inexperienced nurses. We were getting travel nurses with barely 2-3 years experience. And you don't even know what you don't know yet at that stage of the game. Like I said, looking back in 13 years, I look at myself in the beginning going, what was I thinking? And you said it very fine in the sense that it dwindled down. It brought to the public eye what's been an ongoing problem in nursing. And I have an aunt who's now retired 15 years down here from nursing, and she was still getting postcards from places trying to recruit her to come out of retirement when she was a nurse in Virginia, in North Carolina now. So it's very much a huge problem that was highlighted by COVID. And we were all just kind of talking face to face just yesterday of like, COVID put some years on our lives, mentally and emotionally, and you can't get it back. No matter if you talk to your peers, go to therapy, it's definitely dwindled our emotional and mental well-being. The thank you, ladies, for like guiding and bringing that problem and coming up with solutions, more importantly, because we all complain about the problem.
Definitely, I do agree. This is such a huge advocacy. Thank you for being our voice. This is so important that you're highlighting it. And I agree, there's a lot of things that needs to be really, maybe escalated is not the right word, but to showcase that there's more work that we can do. And so my question is primarily, what are the key takeaways from the national work on staffing?
Our 5 key takeaways. The first one is nurses need to lead in the staffing decisions. We need to be a part of the discussion and help to drive that conversation. The next one is that system level, organizational level, and unit level changes all have to happen. And they all have to happen simultaneously and be working on them all at the same time. We can't wait for system level before we start on organizational level, before we start on unit level. It has to happen all at once. The next one is that ratios are part of the staffing question. They're not the end all be all. They have to be kept in mind, but there are so many other things that go into proper staffing. The fourth one, this is safe staffing is not achievable without healthy work environments. And the last one that we came up with is that innovating care delivery models is imperative to improve efficiency. We can't keep doing things the way we've always done things, or we're not going to change anything.
Those are some great points, and I'm sure there's a lot of discussion around them. Where did the task force and the think tank land on regulating and legislating ratios? And do you think that affected the AMSN stance on legislated ratios?
Thank you for that question, Laura. I'm going to address where the task force and think tank landed, and then I'm going to hand it off to Monica. She'll talk about AMSN's stance. So the think tank addressed staffing ratios by saying that staffing standards should be established by specialty nursing organizations. So as Monica said, a key take-home point, and really all the organizations that were part of the think tank agreed with this key point, nurses need to be leading in staffing decisions. So that is really important. Specialty nursing organizations know the patient population and they know the work that their nurses are doing. They're also already setting standards for nursing practice. So AMSN has a scope and standards document. We at ACN, we have a scope and standards document for critical care. So we're already setting standards. So it makes sense for specialty nursing organizations to look at staffing standards. So that's where the think tank landed. The task force work was a little bit different because rather than reaching consensus on all the actions in the task force, what we did with that document was we included all the diverse expertise that was brought to the table. So not every member of the task force agreed with every action, but what we said was, well, let's list them all and let people who are using this tool decide what works best in their context. So we have a recommendation in the task force for examining legislative and regulatory measures that support minimum staffing standards. And then within that recommendation, there's a list of actions, and included in those actions is setting ratios, whether they're patient level ratios or unit level ratios. Unit level ratios allow them more flexibility. Also public reporting and mandated committees. So we just listed a lot of different options in the actions for that recommendation. So I would say that the task force document doesn't endorse ratios specifically as legislation going forward, but it certainly doesn't take it off the table. It puts it on the table as an option.
That's an interesting perspective. And you may have answered this with this next question along the way, but traditionally, staffing has been an issue for such a long time, even before the pandemic. What would you identify as the major barriers to these staffing issues?
One key piece there is the health of the work environment. Even if you bring in the right number of nurses, if they're working in a toxic work environment and they're using an inefficient care delivery model, they're not going to stay. It's what I call the revolving door version of staff,
exactly.
Right? They're not going to stay. Another piece here, though, is that nursing care on the financial side, it really falls as a cost center without a commensurate revenue. We don't bill directly for nursing care. So I'm really excited because out of the task force, under the priority for value of nursing and also other work that's going on, is really looking at that financial equation and really looking at how do we quantify what nurses do and how that improves.
Yeah. What's the secret sauce right there? You know, you take your car in for an oil change, it's billed by the hour, and then the products that you use. Why can it not be more like that in nursing? If you've got somebody with a higher acuity, that's going to take more time, more skill, more follow through. Why shouldn't that be compensated financially? That's a great point.
AMSN has a statement on staffing that does highlight acuity-based staffing, and providing the safe environment for the patient and the nurse is a paramount concern. The patients need to get the resources according to need, and the medical surgical nurse must be able to provide the resources based on his or her licensure, education, and role. AMSN has said specifically that the medical surgical nurse's ability to meet the needs is more important than fixed patient to nurse ratios, that we need to make sure we keep the flexibility and the power to determine the staffing within the nurses rather than handing it off to government agencies and regulators.
I currently work at Moses Cone in Greensboro, North Carolina, and I think something that they've done that's been great for that is they've opened back up the whole lifelong LPN model of having LPNs on the floor, and I think it's greatly helped. So currently I do flex positioning as a med surg nurse to 4 different hospitals, but I've noticed I haven't been called to that hospital as much with their increased use of LPNs, which puts a little more strain on RNs, but it also is able to give more care in a general sense. And I look back at my old managerial position on Cartelli and the old hospital system as I started looking at just a patient number, and it kind of was revolved around tasks for that person, medications for that, etc. And I think the hardest thing about that, especially because we had so many travel nurses at that time, and when you actually know your staff, when you have a staff, I know Caroline can handle XYZ type of patient. I know Marites can handle QRS. I know Laura can handle J through K. And so I'm better than able to say, like, even though this seems busy, I got my A team with me. And so that was some of the challenge I think that has happened. That's why I think they're smart to leave a little bit of leeway in there to make decisions, because you know your team when you actually have a team. So the thing I always think about with my cohorts is I want to be part of the solution, not part of the problem. So how can nurses get involved? What can we do as truly frontline workers? And I've so embraced the moral injury and moral dilemmas we face, because we are soldiers in this tough war with the comorbidities our patients face. What can we do as nurses to get involved?
So first, I like how you talked about the teams that you're on that are using new ways to staff up with LPNs and team nursing. And I think that's some of the stuff that we need to look at. And that was part of the key takeaways from the task force and the think tank, is that we have to innovate and we have to change how we're doing things. And I think nurses, again, definitely need to be involved in that and need to have a say in it. And that's going to take a lot of communication with managers, with units, with facilities, and also with our legislators.
nurses really need to get involved in advocacy and advocating for ourselves. AMSN has a very active legislative advocacy team, and we have a section on the website where you can find that and see what we're working towards. AMSN is also going to be updating the staffing statements, and we're going to be putting forth a call for participants to work on that. And so if you are interested in being a part of that, watch for the call for action, jump in, like you said, be a part of the solution. It's going to take all of us working together, coming up with new ideas to fix all of this.
Sarah, you talked about how are we built, and I'm so passionate with this because during my master's program, I was asking my instructor, okay, RT has the ICD code. Everybody has an ICD code, but we do not have an ICD code. Why are we not billed? So if I take a vital signs, should I be charged $5 for every vital signs, right? And so I think it brings back to, do we need to have an NPI number as nurses? I do know that we can apply for those. And I think, should we encourage our team members to do that?
So that is definitely something that has been talked about. There are some groups that are working on that. We definitely need to figure out a way to quantify our value. The nursing staff is often billed as part of the room rate. And like you said, it's just a cost. And we do so much more than that. And to really capture our value as nurses, we need to be able to quantify it. And using an NPI number is one of the ways that that's been considered. And again, we need to all work together to innovate and figure out that that's probably not the only way to do it. There's got to be other ways. And the more people we can get involved in trying to be part of that conversation, the more great ideas we can find. Because nurses are innovators. Nurses come up with stuff. And so we just need to do it.
That is so awesome because it's been 10 years that we're talking about this. I think there's one actual article that I've seen because I was searching for it. And I wanted to prove to my instructor, we can do it. Why can't we not do it? And she was like, no, that's like shooting for the moon. And that's how we start. You spark an idea, make it work, look for other people, and let's start doing research about it. We can encourage more nurses to join our profession and see our value, that we can really not just make a difference, but also really improve the healthcare system, because that would really be the ultimate goal.
So as we kind of think about everything that's been said so far, is there a multidisciplinary effort out there combining all of the stakeholders? Nurses would probably be the first people to stand up and talk about their value in dollar amount. What do hospital admins think about this? What do regulators think about this? What do physicians think about this? Because they're all about billable hours, just like lawyers. Any thoughts on that?
Yeah, that's a great question. So I would like to circle back. The 5 organizations that were involved in the nurse staffing think tank included the Healthcare Finance Management Association and IHI, as well as AONL, the Organization for Nurse Leaders, and ANA and AACN. That really was bringing together multiple stakeholders. In the task force, we had representatives from regulatory bodies as well as representatives that were nurse leaders in that work. What was really, really encouraging to me as part of the core team coordinating that work was how invested everyone is. So seeing that nurse leaders and finance professionals and others really want to make this better. So while we may not all agree on how to make it better, everyone wants better staffing. That is just a fact. So that gives me a lot of hope for the future.
Yeah, that's great. You've got some real credible organizations supporting you in this mission, which gives me confidence that something may actually come out of this. Where would our listeners go to learn more?
So the Nurse Staffing Think Tank and the Nurse Staffing Task Force work is published on the ANA website. They have a PDF file that you can get to. Monica and I put the QR codes into our presentation. You can find the work on the ANA website. Though the work was collaborative across multiple organizations, the best place for us to post it was on the ANA Nursing World website. You can also learn more at AACN's website, and AMSN has recorded, I believe, the presentation we gave yesterday. Is that right, Monica?
Yes, that's right. The presentation was recorded. It will be available in a few weeks for all convention attendees. Not sure yet if it will be out for everybody to purchase for CEs later. They usually are. You can also go to the ANA website and check out their ECHO series, which is an educational series that's going over the 5 imperatives that came from the think tank work. And that each week will cover one of the imperatives. They'll have a presentation by a subject matter expert and then an interactive small group discussion. It's already started, so you won't be able to participate in the small group discussions obviously for the ones that have already happened, but they did record them, so you can go back and watch the subject matter expert portions. And once you register, you can take part in the upcoming discussions.
Sarah and Monica, it's truly been a pleasure having you on this special convention episode of Med Surg Moments. Thank you so much for sharing your time and expertise with us.
Thank you so much for having us.
Yes, thank you so much for having us. It was great to meet everyone.
We look forward to connecting with you on the next episode of Med Surg Moments, the AMSN podcast. In the meantime, we want to hear from you. Send us your questions, topic ideas, and feedback via our official Med Surg Moments email address, amsnpod@amsn.org. That's amsnpod@amsn.org.
I'd also like to remind you to become a member at AMSN or renew your membership at www.amsn.org. You receive lots of cool benefits and perks, such as discounted pricing on the annual convention and continuing education.
We encourage you to help us spread the word and subscribe to the Med Surg Moments podcast via your smartphone podcast app to receive notifications of future episodes. Please be sure to leave us a review and recommend Med Surg Moments wherever you get your podcasts to help us reach even more listeners.
I invite you to join the conversation by sharing your ideas and questions on AMSN's Facebook, Instagram, LinkedIn, or Twitter pages. And don't forget to add hashtag MedSurgMoments to your posts. Simply enter AMSN in the search field on any of these social media platforms to connect with us.
The content within the Med Surg Moments podcast represents the views, thoughts, and opinions of the co-hosts and may not necessarily reflect the views, thoughts, and opinions of the Academy of Medical Surgical Nurses. Until next time, I'm Caroline.
Laura.
Neil.
And this is Meredith. And always remember, Med Surg Moments is a moment in our lives, a moment in our Med Surg careers that makes a huge difference.